PARTNER trial has been critical in our understanding of TAVR, how it is used, and particularly which patients are going to be the most optimally treated. So now we're here at ACC 16 and we have the PARTNER 2 trial results, some of which will appear in the Lancet and others in the New England Journal of Medicine. And to talk about all of this, I'm with Dr. Vinod Thourani, who is an MD, and he is professor of surgery and medicine at Emory University School of Medicine and co-director of the Structural Heart and Valve Center there. Let's begin with some background. Tell us about the rationale and design of PARTNER 2 before we get into some details.
Sure, absolutely. We started with PARTNER 1 with extreme risk and high risk. So obviously the next generation would be going to lower risk patient populations. So PARTNER 2 was designed as a randomized trial. PARTNER 2A was designed as a randomized trial looking at intermediate risk patients and randomizing them to surgery, open surgical therapy versus transcatheter valve therapies. And at that time when we started the trial is with the SAPIEN XT valve. As many of you may know in the world, SAPIEN XT has now been moved over by SAPIEN 3.
Exactly.
So the second arm of the PARTNER 2 trial was actually looking at the PARTNER 2A SAPIEN 3 trial. And that was a registry of over 1,000 patients looking at the PARTNER SAPIEN 3 trial, and that was compared to the surgical patients of the PARTNER 2A trial. So really, we're presenting two trials back-to-back Saturday and Sunday here.
Now, as always, results apply to patients who are similar to those enrolled in the study, so let's specifically talk about the patients enrolled in PARTNER 2.
Right. So the PARTNER 2 patients are intermediate risk patients, and these were classified by starting off with an STS score, somewhere between 4 to 8. And those patients, however, it was decided on by our team that this was going to be an intermediate or medium risk patient. So there are some patients who were less than STS 4 because there are certain variables within the STS score that are not captured within the calculation, for instance, cirrhosis or frailty. So we're looking at an intermediate risk population designated by the STS score, but also really honed in by the heart team.
And the heart team is obviously critical in this issue.
Absolutely critical. It's cardiologists, it's surgeons, interventional and non-interventional cardiologists, sometimes neurologists are involved, and a variety of echocardiography and anesthesia consultants also.
So your primary hypothesis is non-inferiority of the SAPIEN XT versus control or surgery for all-cause mortality or disabling stroke at 2 years. What did you find?
So Dr. Craig Smith presented this study here Saturday at 2016 ACC, and we found really we met that primary endpoint of non-inferiority. And so we're really looking at a similar technology with less detrimental effects early on, but we're looking at a non-inferiority primary endpoint that has been met.
And what about your presentation?
So the presentation of the SAPIEN 3 compared to the surgical patients of PARTNER 2A, quite interestingly, not only did we meet non-inferiority, by the way, our primary endpoint was slightly different. It was for 1 year, and it was a primary composite endpoint of all-cause mortality, all stroke, and a moderate aortic regurgitation, or greater than equal to moderate aortic regurgitation. We found not only was it non-inferior, SAPIEN 3 that is, but it was superior to the primary endpoint compared to surgery. And on top of that, it was superior for the individual mortality endpoint, for the stroke endpoint. We did, however, find that in the surgical therapy for the individual component of AR greater than equal to moderate, surgery was superior to transcatheter valve therapy, so the SAPIEN 3 valve.
So what are the take-home messages from this?
It's quite interesting. I think that for the first time we're seeing a transcatheter valve technology with a SAPIEN 3 being shown to be superior to surgery in a propensity score analysis. So I think we have to redefine, or at least rethink in our minds for the heart team, are we now seeing a superior therapy in transcatheter valve therapies?
And what's next?
I think the next thing is to, first of all, to continue to follow these patients. In SAPIEN 3 trial that we're talking about, we need to know more than 1 year outcomes. We need to know what happens at 2 years and 5 years. That's one thing that we have to continue to look at. Number two, I think that, of course, we've now started low-risk trials. Exactly. And so I think that we have a variety of programs that are starting low-risk trials. I think we're really starting to scratch the cusp of what's going to happen for the management of severe aortic stenosis over the next 5 years.
Now we have the Cert IV trial too, correct?
Right.
And what are they looking at?
So Cert IV trial is very analogous to the PARTNER 2A trial, and that will be published in New England Journal of Medicine on April the 2nd. And that is very similar trial design. It is just using the Medtronic core valve versus the SAPIEN XT valve.
The take home for you is obviously to now consider patients who are moderate risk, as long as it's being evaluated by the heart team.
Absolutely, and plus we have to wait for, in the US, we have to wait for FDA approval. FDA approval is not, has not been done yet for intermediate risk patients. Now for the first time at ACC 2016, we're presenting 3,000 patients who've had transcatheter valve therapy, adjudicated patients with 1 to 2 year long-term, 1 to 2 year follow-up, and we'll be able to really start, hopefully the FDA will look at this very critically.
Well, I think it's fascinating, and I think Partner is just going to continue teaching us a lot more about this. When do you think we'll have some data regarding the low-risk patients?
Well, that's a good question. We're starting the trials now in 2016, so a couple of years.
Wow. We'll be talking again, I suspect, somewhere down the line.
Yeah.
So check out Lancet, please, and New England Journal of Medicine for the results from the papers presented here at ACC 16, where I'm the executive editor of CardioSource World News, Rick McGuire.